Hi, my name is Danielle Matias, and I'm a PA here at Caring Medical Florida, sharing with you an interesting case that I saw recently in the office in a 14-year-old male. This patient is an elite soccer player. He's been playing soccer since he was 2, being looked at professional teams already, but was diagnosed with an osteochondral defect in his knee. Now, by the time this patient ended up in my office, he had done all the things, right? He had done all the physical therapy, he had rested for months, and per his orthopedic that he was working with in his hometown, it just wasn't getting better. They kept continuing rest, trying to play soccer with a brace. Nothing seemed to be working, which is how they ended up in our office. So in an osteochondral defect, we oftentimes call it an OCD of the knee. If this is the bone here in the knee, this is the cartilage. Okay, so an osteochondral defect basically means that a chunk of this becomes injured and maybe even breaks off. When somebody has failed all conservative treatments, right, they've rested, they've done all the physical therapy, they've done all the things, and it's not getting better, then we have to start looking at the knee as a whole, not just the knee related to that OCD. And if we look at this graphic of the knee, you'll see a lot of white soft tissue. These are ligaments. These are the rubber bands that hold our knee together, hold all of our joints together, but hold all of the bones of our knee together. And if the ligaments become stretched out, like a rubber band that's stretched out that now is just floppy, it doesn't recoil to its normal tightness, what happens is it puts extra strain on the bone, on the meniscus, on the cartilage. So I oftentimes do this. If this fist is a bone and this is a bone and they're unstable and they're moving more, you could see how that friction could start to wear down or affect that cartilage in a negative way. In this patient, we did a dynamic ultrasound exam looking at the medial and lateral knee for MCL, LCL, laxity, injuries, and tears. Well, this patient actually had a pretty good medial knee. MCL, pretty solid, not unstable, pretty tight to valgus stress test. And on the lateral side, though, did have lateral ligament laxity and positive varus stress test, meaning that when I went to put a little bit of strain on his knee, that lateral side moved more than it should. And that's where his OCD was. So this is his original motion x-ray. You can see, 14-year-old boy, he's still got growth plates open. But if you look in here, this is the lateral side of his knee on his femur. That, where it kind of looks like someone took a bite out of the bone, that's his osteochondral defect. This is our x-ray on day 1. Here's just a still of it. You can see right here, this nice healthy bone right here, and then someone took a bite out of it. So because this patient has this OCD, because he has a lateral knee instability, I recommended doing a combination of dextrose prolotherapy and PRP. Dextrose prolotherapy works really well for ligaments, works really well to get them to tighten and strengthen and restore stability. PRP, because I'm trying to use this patient's cells, his growth factors, to try to fill in that defect. I do not believe that just doing PRP on its own in the knee would have helped this patient because he did have that lateral knee instability. I think if I had just kind of ignored these lateral ligaments and just let them be floppy and let the joint be loose, I don't think that would have been a successful treatment for him. This is a follow-up x-ray after we had done a couple treatments on his knee. So again, it's not filled in completely, but it is smaller, this osteochondral defect. His ultrasound exam also did reveal that his instability was reducing as well. It was not fully stable yet on that lateral knee, but we were trending in the right direction. So here's that kind of bite out of the knee right here, filling in well on this side, still have that to go. This patient also was following up with his local orthopedic, who also agreed with us. He was also doing his own set of x-rays, also agreed, yes, this defect is filling in, this patient is doing a lot better. After a couple of treatments, did I clear him to go play soccer right away? No, we have to be smart about this, right? We gotta ease back into sports. We gotta ease back into his activity. The last thing I want, especially for a young patient, is to go, back at 100% and then they, maybe re-injure their knee. It wasn't quite ready. And that's a hard mental thing too. You know what I mean? When you try to play your sport and it keeps hurting you, we gotta be smart. We gotta ease back into these activities, not going back at 100%. This patient is still under my care. He's still being seen for treatment. When I do follow-up x-rays again, I do expect that I see more healing with that OCD. I do expect that his knee does get fully stable, and I'm excited to report on that. So just in summary, dynamic imaging, very helpful in the diagnosis of this patient. Yes, we already knew that he had the OCD from an MRI, but we had no evidence of the lateral knee instability that was present there. So I'm glad we did that. Prolotherapy and PRP is an effective treatment for getting our athletes back in the game. One other thing, I didn't mention this before. So while I was treating this patient, he was not playing soccer during that time, okay? It wasn't his season to begin with, but it is important just in general when you're treating athletes to remember that we do need to rest in order to heal. So can we treat athletes in their season? Of course, it is optimal to treat out of season when we can.